Hi, this is Elliot Fishman, and welcome to part 2 of our talk on CT angiography, looking at the role of CTA in the evaluation in the oncologic patient. We're going to look at a range of different applications, talk about protocols, and let's get started with part 2. We spoke about the liver in detail in the first part and just started getting to the pancreas. So let's pick up the pancreas. We'll talk first about adenocarcinoma. Obviously, we know the challenges of adenocarcinoma are early detection. If you can pick up tumors early, stage 1, stage 2, you talk about a 40 to 60% 5-year survival. And when you pick things up later, like stage 3 or stage 4, you're talking about a single-digit 5-year survival. So it's very important for us to try to optimize detection of pancreatic cancer. With CT angiography and dual-phase imaging and the use of 3D mapping, particularly with things like cinematic rendering, what we're trying to do is accentuate the difference between normal gland and tumor. We don't want to pick up tumors just because they're large. Again, size is critical, but we talk about 2 cm or less, 40% of lesions are missed. So we want to look carefully for subtle changes to pick up lesions which can fool us by being nearly isodense. We want to look for the presence of a pancreatic duct and potential duct dilatation. We want to look at that very, very carefully. And then, of course, staging. Arterial phase, looking for staging at the celiac, the SMA and its branches, GDA, hepatic artery. We also want to look at the venous side of things, looking at portal vein, splenic vein, and SMV. In this article by Ahmed, we talked about how it's very easy to miss pancreatic cancer. Things can be subtle, like in this case, this was 6 years earlier. There's a very subtle change in the body, which later becomes a tumor. We look for things like focal atrophy. One thing we look for now is changes in enhancement. Some people talk about areas of increased enhancement. Our experience is more areas of decreased enhancement, but also looking at the texture, looking at the vessels, and looking at the pancreatic duct. Again, this overlap in features are often a challenge to us. Sometimes patients with pancreatitis can be hiding a pancreatic cancer. We know the rule is if there's no good reasons for pancreatitis and you see a dilated duct, you better wonder if the reason the patient has pancreatitis is secondary to a small tumor that's going to be in place. So again, there are a lot of things we know, but this title of the paper, Hidden in Plain Sight, is a very good way of thinking about things that in retrospect, sometimes we will see the lesion. Now, I have to admit, sometimes even knowing where it is, I can't see it. That's where a lot of the work that's going on with radiomics may prove to indeed be very, very helpful. Now, when we talk about PDACs and we're talking about tumor involvement, it's really the CT angiography that's ideal. Otherwise, you spend a lot of time looking at abutment. Is this 180, more than 180, less than 180? Is the vessel abutting or is it encased? On CT angiography, looking at things from the coronal and the sagittal, from the volume rendered views in similar planes, we're able to look for subtle changes in the caliber of the vessel. We look for irregularity of the vessel itself, and we're much better able to judge whether something is 180 degrees, over 180, or less than 180. So again, CT angiography becomes very, very important. I mentioned about the vessels. We do specific maps of the celiac and common hepatic artery and SMA. We look very carefully at the vessels. We look for the areas surrounding the vessels. Is there soft tissue encasing the vessel? Is the vessel narrowed? When the vessel is occluded, that's pretty easy, and that's particularly true on the venous side, where portal vein SMV inclusion can occur, but it's this more subtle involvement that CTA is particularly helpful for. Also, at times, when you have tumors which show encasement of vessels, particularly the SMA, you may not see a tumor till you'll realize that there's a tumor coming off the lower portion of the uncinate process. So simple examples. Here's a patient, dilated pancreatic duct, atrophy of body and tail, and here's a cutoff right here. Now, I don't see a specific mass perhaps, though I would say there's one here, but just seeing the duct cutoff and the transition, That's a pancreatic adenocarcinoma until proven otherwise. Here it is on the venous phase. I think you see the transition a little bit better. That's a carcinoma. Here's a cinematic rendering where you show the textural changes with glandular atrophy distally. You see the dilated pancreatic duct, and you see the textural changes which represents a tumor. Now, as I mentioned before, we want to use CT angiography for looking at the vessels and staging, but I think also the concept of looking at the pancreas as a volume rather than a series of hundreds or thousands of slices is better. CT angiography with 3D mapping, we mentioned cinematic especially, can help show tissue differences between normal gland and abnormal gland, and that's something we're looking at very, very carefully. Now, the SEER data shows that 12% of patients with pancreatic cancer have stage 1 disease, 52% have stage 4. So you can see the biggest problem we have is the fact tumors are picked up late. It used to be felt that, well, today you're normal, tomorrow you have pancreatic cancer. There are a lot of articles now that are showing, particularly with these early changes of pancreatic cancer, that it could be anywhere between 3 or 4 years when the patient has cancer till it's detected. Now, we wish we could pick them all up earlier. The positive of the statement is that if the patient takes a number of years to get the tumor, or it's very subtle till you can see it, and you have some time, perhaps if we can improve detection, we can pick up tumors when they're earlier stage. Remember, stage 1A pancreatic cancer, 5-year survival is better than 80%. We talk about screening for pancreatic cancer. This article was just published. We do screen limited patients, those with high degree of family histories or certain syndromes, but for most patients, screening would be just too difficult, too many false positives. Remember, there's only 61,000 cases a year in the U.S. It's about 1.7%, but the point being that screening would not really work out well without a lot of false positives and very expensive screening with very, very poor results. But again, what's important, as this article shows, that I mentioned a few moments ago, is to look for the things early. Here they say 1.8 to 4.6 years before diagnosis, there's focal atrophy. At 3.3 years, there's fibrosis and even maybe faint hyperenhancement. And a year before diagnosis, there may be duct cutoff. So again, there are subtle findings beyond seeing the mass. And I think one of the things we're looking at with AI is, can we pick up these subtle findings? So it's not just seeing what the radiologist can see now. That'd be good if you can train the AI to be as good as us. But what we're looking to do is make AI better than us. Just some examples: subtle lesion, a couple centimeters tail of pancreas. You can see it's hypodense, and you see it very nicely here on the cinematic. On the cinematic, you get a good look at the texture of the gland. Here's that same patient. Remember, with cinematic, I can change the texture. And so one of the things I'm working on is how to figure out what the best texture is for a normal gland so that I could pick up even subtle findings. So you see the textural change here. You see the dilated duct distally. In this case, here's the mass, subtle. There's a dilated pancreatic duct. And there's the mass again, very nicely showing the textural changes, but also the duct cutoff. And again, when I look at things through the axis along the pancreatic duct, you can see the dilated pancreatic duct, that transition, and that under 2 centimeters hypodense mass. When you pick up masses at this stage, there's no liver mets, there's no vascular encasement. This patient should do very, very well. And here's that same patient with the cinematic rendering. Another patient, this was read as negative, but if you look, there's a subtle lesion. You look at the head of the pancreas, you see the SMA, SMV, this is arterial phase, and then here's the tumor. It's subtle, but it's there. Okay, it's there. And you can see it again on the cinematic rendering. So those are really the tumors we need to pick up, and we need to pick up tumors even smaller than that. It's really the only thing right now that's going to change the game is early detection of pancreatic cancer. And again, here's a nice example, same patient, textural changes in the gland, and there's the tumor. There's portal vein, there's the patient's splenic vein, there's SMA, there's celiac and hepatic artery. So the 3D mapping is ideal for this application, and we are trying to figure out how much better we can make it. This isn't as subtle. Patient with gastric outlet obstruction, stomach is distended, duodenum's distended, and you see why the patient had a mass arising from the tail of the pancreas, which invaded the junction of duodenum and jejunum by the ligament of Treitz. So it was really a tail tumor causing obstruction of the small bowel, which resulted in the patient's gastric outlet obstruction as well. Just a really nice example here. On the coronal view, there's the tumor. Here it is in the volume rendered view. There's the tumor. And here it is from volume rendering to cinematic rendering. Again, look at the textural changes of the tumor compared to the normal head and uncinate process. So again, one of the things we're trying to do is rethink things, not so much looking for masses, but looking for textural changes. So just a really nice example. And we believe that cinematic rendering does have really good potential. We are using cinematic rendering, as this article by Mars shows, to do preoperative planning. So it's very important in detection of tumor, preoperative planning, and eventually follow-up. Another case, markedly dilated pancreatic duct, atrophy of the gland. You don't see an obvious mass, but then when you look along the center line, this must be the mass sitting right inside the patient's pancreatic duct. And there it is, very nicely shown on the cinematic rendering. You see the loss of gland here, this textural change, and the gland is smaller, and there's the duct obstructing, and that's the patient's tumor, better appreciated on the cinematic views, nicely shown again in this example. So one of the things, again, we'd like to do is automate cinematic rendering, and we're working on that so it's not a lot of the individual variation between how you look at it, and also the fact that most people don't do cinematic rendering. If cinematic rendering works well for detection of pancreatic cancer, we need to get people to use it, but to use it, it needs to be basically automatic. Here's another example from that same case of the dilated duct. Look at the chambers of the heart. This is just the idea of showing you how I can really change the textural maps of the gland. One of the things, of course, with cinematic rendering is varying the texture, but you want to make certain that you vary it to optimize lesion detection and not minimize lesion detection. Another case, here's a patient with a vascular lesion in the head of the pancreas. When you have vascular lesions in the pancreas, they're typically neuroendocrine tumors. The only exception, perhaps, is metastasis like a renal cell, and here the kidneys look good. Here's the coronal view, very nicely showing that 1 centimeter lesion. And here it is with a cinematic rendering. And again, cinematic rendering is very good for picking up these lesions, showing the difference in texture. And now most places will pick up, in a patient without a syndrome, 2 centimeters or less neuroendocrine tumors will simply follow the patients rather than operate. Again, showing you the detail. Here's that cinematic rendering where I show you the tumor, show you the celiac and the SMA. Here's another case. This was a neuroendocrine tumor, and you say, what neuroendocrine tumor? Well, if you're looking carefully at that scan, I have a hard time, even with the circle, seeing anything here. Is there some minimal texture irregularity? That's kind of subtle. Coronal volume rendered view, still, I don't know. But there it is on the patient's cinematic rendering. It's a 1 centimeter hypervascular lesion that was a neuroendocrine tumor. There it is again. See the texture of the gland? And here's the lesion here. So again, the textural change showed us the lesion. Now, the truth was this lesion did show better on the venous phase. But again, it does make the point that the texture changes will be better. Here's a lesion again near the patient's body of the pancreas, hypervascular. Here it is sitting adjacent to vessels. That's the lesion. That's the normal gland. Look how nicely this stands out. Remember, we showed you adenocarcinoma a few moments ago, and that stood out as kind of a negative. Here, this is a positive, typical neuroendocrine tumor of the pancreas. And these things are often missed. Remember, we just published an article that shows that radiomics can detect tumors more accurately than radiologists. Another example here, we talk about neuroendocrine being vascular and seen mainly only on arterial, though usually you see it on both phases, but best seen arterial, then it washes out. Here in arterial phase imaging, I don't see much. Do you want to argue some textural changes here? But gosh, that's kind of a little bit difficult. Maybe here, but that's not vascular. That's just maybe a suggestion of textural change, which is shown very nicely on the cinematic as well. And then you go to venous phase, and look how obvious the lesion is. So not every neuroendocrine tumor is best arterial. Some are best venous, but this is a nice example showing you, although we don't see the mass per se, when you go backwards on the cinematic, you can see the textural changes in the gland where the tumor was. So both in neuroendocrine as in adenocarcinoma, we may be dealing with textural changes that we don't appreciate when we look at the axials alone, but this becomes very obvious. And so this patient, because the lesion was relatively small and the patient asymptomatic, it was biopsied, low grade, and the patient was simply followed. Now, the same thing is true with cystic lesions. Now, we talk about the difficulty determining what a cystic lesion is, how we follow cystic lesions, IPMNs, are more common in older patients. We talk about serous cystadenomas, which are always benign, but have a range of appearances. We talk about mucinous cystic neoplasms, more common in the body of the pancreas, usually 40-ish-year-old females with a high propensity for malignancy. We talk about neuroendocrine tumors. I just showed you a couple, but they can also be very vascular. And then SPEN tumors, which are cystic and solid tumors, more common typically in younger patients. When we talk about serous cystadenomas, it's about 15% of cystic lesions. And again, it's funny, it's an age-related. They're called grandma tumors because they're in their 60s and 70s or 50s and 60s. It's more like 60s and 70s. And MCNs of 40s and 50s. We talk about the variability in types, and we've spoken about that in a recent talk. The most common is the microcystic, then macrocystic, mixed pattern, and then a solid pattern. With SCNs, we don't see communication with the pancreatic duct. They can be very large. You can see the septations here. The CT angiography shows draping of vessels on the lesion. There's no neovascularity and there's no invasion on the arterial mapping. And then on venous, you see the septations better. So a very nice way of looking at a serous cystadenoma with a little bit of calcification. And you can see on the cinematic rendering how much better you can really accentuate all of the septations. Here's another example, large serous cystadenoma. Almost looks like a GIST tumor coming off the stomach. There's no dilated duct. We talk about the stretching of the vessel around serous cystadenomas. If the other mass was a carcinoma or was a neuroendocrine tumor, you would see distortion of the vessels, not simply stretching around the edge. That's a very classic sign for a serous cystadenoma. I've also found that the cystic components of the lesion, particularly the smaller cysts, may not be appreciated on arterial phase, but are very much appreciated on the venous phase imaging. In this article by Wang, pancreatic cystoneoplasms that show central scarring, central calcification, or the circumvascular sign are considered serous cystadenomas. And this draping sign that I just showed you is what they call the circumvascular sign. If you have neuroendocrine tumors, you can have stretching of the vessel, but the vessel will be irregular. So it's a very helpful sign, I think. And again, arterial phase imaging, and when you see it, you're typically in the serous cystadenoma ballpark. And again, just some of the comments here, combining the circumvascular sign with either of the other features increase sensitivity of diagnosis to over 80% for serous cystadenomas. So things you'll look for, the septations, the central calcification, and the circumvascular sign. Now we talk about serous cystadenomas in 3D mapping, showing you the septations, showing you the vascular map even better. Another example, large cystic lesion body of pancreas. In this case, the duct is minimally dilated. We talk about no dilated ducts with serous cystadenoma. Well, that's not always going to be the case. Again, coronal oblique views are very helpful in this regard. And here's the cinematic rendering also very nicely showing you the tumor and showing you the multiple septations. When you have these solid serous cystadenomas, they can fool you in that they look like neuroendocrine tumors of the pancreas. You don't have that vascular sign with stretching of the vessel that can be helpful. Remember, neuroendocrine tumors of the pancreas can calcify, as can serous cystadenomas, so that alone may not be that helpful. I think on the image on your left, as you get to venous phase, all of those septations really push you to serous cystadenoma and away from a neuroendocrine tumor, which washes out from its vascular state, but usually is still going to be more vascular. Here's that circumvascular sign of the patient's GDA and part of the hepatic artery. And again, here it is as you go to venous phase imaging. Large lesion, again, differential, would include, and was a serous cystadenoma. I would include perhaps, I would not say a pseudocyst, I would not say an IPMN. It's not a great location for an MCN, but it could be. Doesn't have the typical look you would see with a SPEN tumor. So again, very nice example. Another case here, and we'll stop after this case, vascular lesion, incidental finding, solid mass. First thing you think about is a neuroendocrine tumor, vascular, but then you look, there's draping of vessels, and here's the lesion on venous phase. It kind of begins to wash out, and I see all sorts of septations. Here it is on the cinematic where you really see the lobulations oh so nicely. And again, here it is showing you the multiple septations. This has the look of a serous cystadenoma, not the look of a neuroendocrine tumor. Again, both were hypervascular, so there is that branch, that solid serous cystadenomas, which can indeed be very, very vascular. So let's do this. Let's stop there. We've covered a lot of things. I want you to think about them, and let's come back and talk about how CTA can be helpful in the diagnosis and staging of mucinous cystic neoplasms of the pancreas. We'll be right back. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.